Hello, everyone. I'm sorry. I'm late to this meeting. I'm dealing with a pregnant wife, so you can only imagine. But hi, nice to see you all. Yeah, I don't know what has been said till now, so I think I'm gonna let the residents just. Do you have any cases like, and then maybe I'll talk some more. All right.
I think that we can talk about the case we have on Friday.
Oh,
can you talk about the case we had on Friday? That's the trauma case.
I'm sorry, I forgot. My name is Ezio Masinga. And I'm one of the emergency medicine specialists from Mozambique. So nice to see you all.
Wait, Brito, are you talking with me? Friday?
Yes. I was talking. Are you able to present that case we had on Friday? It was very interesting one.
Which one? We have a lot of cases, difficult case, but
the trauma case.
Okay. Yes, I can present that one. We have a patient this Friday. Is a male, and he came from the hospital of how can I say? Manisa, and other district. And they came with the patient, but he was conscious, and he was bleeding all in his face and all places we can see. But the thing we see that the patient was a little bit calm, and we start to see that we start first to approach him, the ABC, and when we speak with him from the A, he was not able to speak, but he can respond everything we ask him to do. So, and we see the, how can I say, saturation, and it was 98% air ambient, and he didn't have difficulties about that. But we tried to see the B, and it was fine, and the C was fine too. But somehow the patient was bleeding, and when we made the blood pressure, it was 73 for 32, very hypotension. So we start with fluids, with lactato and very quickly give him to IV access, and start the fluids in the patient, trying to make his blood pressure get a bit high. And we start to see that this patient was bleeding, not just from the face we are seeing that, but somehow he was losing a lot of blood in some place. So we take the patient immediate to the ICU, and in the moment that we call everybody. The problem that was, first we called to the neurosurgeon and neurosurgeon, and was difficult because in Mozambique somehow the doctors have a little bit of difficult to accept other calling from emergent medicine or other colleagues. They just want to be called from someone high, and they told I was just a resident. But we discussed a lot, and the doctor said, okay, I will be there. We start to make try to resuscitate this patient with fluids, and we gave 2 liters, and then we make a fast, and we saw that he was not bleeding from the first was negative, and we make how can we say echo, we try to see the pulmonary situation, and was fine. suddenly when we are cleaning his mouth, he vomited 2 liters of blood. And it was scary for everybody, but I think that emergency medicine have a different approach and we didn't get scared so much. But we start cleaning this patient, give another, try to find another IV place to put him, another liter of fluids, and called now the other specialists, maxillofacial, and the otorino, hand, and we start to call the surgery people, a lot of specialists to see where this patient was bleeding. And it was amazing because 30 minutes over, we saw that the blood pressure was 103 and 79. And we feel like, yes, we are making a difference now, because I feel that the problem was that all of the specialists was getting late, and something have to be done very quickly. And the resuscitation department wasn't accepting that patient. They say that we can take this patient, and we stayed there trying to do something for more than 1 hour with this patient, and giving fluids him and trying to stop the bleeding. And somehow they decide it was neurosurgery problem, because he'll have a lot of fractures on the face, complex clofoid, and you have traumatism, basic skull fracture, basal
Nasal skull fracture.
And he had some fracture in the mandibula, and a lot of other. But they decided that it was important him to make MR, but they just how can I say, it was a little bit frustrating to know that they didn't want to do that because the patient was bleeding. So we stopped. And why? But yes, they take the patient to the
ICU.
No, the ICU didn't accept the patient. The SO, yes, the observation room, and stay with the patient and trying to do something and waiting for the MR to accept him, so that he can go and make surgery to correct the problem, because he was bleeding from the how can I say, the noise. Yes, no one knows where is bleeding coming out, but was from the skull, from inside him. And yes, it was amazing to do that, because we found some patient that was almost dead, and with the first 30 minutes of our actions, the patient get a little better, and we make some difference with this patient. Even when everybody doesn't want to take the patient, we take the patient, we treat the patient, we stabilize the patient, and we waited just to him to go to the surgery room. Thank you.
Very well done.
Brito? I don't know.
Yeah.
Yes.
Yeah. I didn't introduce myself. Hello, I'm Brito. I'm also one of the new emergency medicine physician who graduated just last year. So I was with Dorli when we handled this case. What I thought very amazing in this case, it's because after we stabilized the patient, no one of the surgery team assumed he accepted the patient as his patient. All of them, they were saying that no, it's not my patient, because it's still without the MR. So it was So my network went down. So I was saying that what I thought amazing, it's because we were able to handle with this patient, which no one of the surgery team was accepting him as his patient. That is one of the kind of the problem we're facing here in Mozambique. The first problem we have, it's because the ICU team does not believe us, and they think that we must learn with them to manage the patients. While we're managing the patient differently than ICU patient, because we have been at the ICU using their way, which we don't agree how they're doing the things, but they're saying that we shall start with them managing the patient, what is very, very sad, because they are looking for us as challenging us. We are going to challenge them to take their place. They don't see us as a part of team, which we are going to do what they was doing before. So that's something which some. So I was saying that it's some of the problem we're facing here, because some specialists they don't believe us. They're seeing us as someone who is going to fight them, not to work together as a team. I remember, for example, that patient Dorle presented maybe at about 7 p.m. when we are going to go out. One of the residents who surgery residents said that you didn't do nothing while we did everything. No. So I was saying that we are facing a lot of challenge, because the first thing we do have, it's because we don't have enough space to stay with the patient for a long time. So we have to stabilize and then send to another department, which is not good, because they'll do the things using their way. And we would like to stay with the patient with a more long time, but our space is only for one bed, only one stretcher. So you manage to see one patient each time, what is not good, because sometimes we manage to stay 1 hour only, because we don't have enough space to stay more time with the patient. But we are hope, because maybe next month we're moving to another site which is more bigger than the the, the space we have now. So it's a very things, but I think that we are handling a little bit of it.